the format that we'll follow is we'll present cases. There will be 5 cases in all. And after each case, we have experts who will give their tips or surgical pearls related to the case. And these would be in terms of the diagnosis, management of the patients. And if it's a surgical case, we'll also have experts presenting their tips on how to manage these patients. So to begin with, we'll first start with Dr. Darius Shroff, who will be presenting on rhegmatogenous retinal detachment with macular hole, what went wrong.
Good morning, everyone. I'd like to thank Dr. Aniruddha for this opportunity, and I'm going to present something which is titled Top Mistake in RD. It was a 75-year-old lady who noticed diminution of vision in the left eye for a week, and right eye was normal. Left eye vision was 3/60 N36, and she had a posterior pole RD and underwent a vitrectomy. The RD had a macular hole also, so she underwent vitrectomy at ILM peeling. I'll just show you the color photos and the video. So here you can see basically nasal retina is attached, temporally it's detached, and you can see the macular hole, which has also been seen in the spectral domain OCT below. You can see the MH with RD nicely. So it's the video, we hope it works. Yeah. So in fact there's some music, but you can see we're doing the PVD induction and injecting the blue dye. And here we find there's a ERM which we take out first, and now we restain and we are removing the ILM. I thought it was a large hole, so we like to have an inverted ILM flap and make a small retinotomy drain with the 38 gauge needle, but lo and behold, the flap is jumped into the brush needle, and now all sorts of tricks are being done to kind of remove this flap from the 38 gauge needle, including injecting saline to kind of remove it, but nothing happens. Lo and behold, there's a small hemorrhage also at the drainage site, which is also worrisome, but the retina is attached, and we kind of get away, but with some things to learn. And retina well attached, but patient is not happy, and vision acuity post-op is not really improved. The macular hole is closed, but there's extensive RPE changes. So this is what the posterior pole looks like. This is the autofluorescence, which is pretty scary, and you can see a beautiful OCT from the retina reattachment point of view, but you can see the atrophic changes and the thinning which is seen on the OCT. So in fact this we have jointly published with PGI and Dr. Karkes's group with Dr. Aniruddha, Dr. Vishali, and this about the RP atrophy after with another case from the institution. So wanted the comments of Dr. Mahesh and the panel.
I think we are seeing a lot of patients now who are undergoing very routine macular hole surgery or epiretinal membrane surgery, and where ILM blue or similar dyes are being used, and we are seeing the RPE changes in the post-operative period. So does anyone in the audience have any experience while I invite Dr. Shanmugam sir for his comments? So if you can please.
That's quite surprising. I can't say that I have seen anything like this in any of my patients. So 2 or 3 things which were coming to my mind. One was whether the dye used was in fact Tryphon blue or ILM blue, but you had indicated it was ILM blue, and I did read your article as well. So if it was Tryphon blue, there was a possibility that can give rise to more of a toxicity in the subretinal space. Other than that, if a myopic patient under subretinal dye, a combination of that, whether it resulted in it. So you did the fluid gas exchange, did the subretinal fluid drainage, and after that again you injected the dye, isn't it?
No, sir. It was only done in saline. It was not injected.
So there was no dye which was...
No air interface.
No, the dye did not persist in the subretinal. We didn't leave behind dye in the...
We didn't leave behind, but a very small quantity definitely could have gone through the hole. I mean, but it was not visibly there, but definitely there could have been some component which.
Okay, because if there's a persistence of the dye within that confined space, that could have resulted in it, one.
Definitely.
Second one is like putting a viscoelastic at one point in time is the question, because putting a viscoelastic will go under the retina into the submacular space.
Yes.
So that may interfere with closure of the hole. So if at all, like what I would do is like to put a perfluorocarbon liquid and try to peel the ILM beneath that. That may be a little bit easier rather than peeling it with the detached retina. So in such a situation, what happens is the dye can go into the subretinal space, remain there and can cause this. But frankly speaking, like I was quite surprised to look at the post-op images. I don't think I have come across anything like that so far. Do you have a habit of like adding any antibiotic into the infusion?
No, we don't, sir. We don't.
No antibiotic into the infusion, no antibiotics in the subconjunctival space at the end of the surgery?
We do give decagenta, but I don't think this is not looking so much like a
because like
infarction.
inadvertent,
Yeah, I know that
inadvertent like changes do happen. I'm not saying that way, because like in one of my colleagues' patients, so he used the sponge to peel the vitreous.
Okay.
So that's a technique which is described.
Yes, yes.
So we use the cellulose sponge, cut it, hydrate it, and you can use it to peel the vitreous.
Yes, yes.
So post that, he found a lot of necrosis of the retina. So he came and showed me. I asked what could have been the reason. So that patient incidentally had a belt buckle also. The sister had soaked the buckle in the thing. So in that, probably some mistake has happened, that some amount of the dye, the gentamicin has gone into the sponge, which would have given rise to that.
But this patient, because it was posterior pole, we didn't, although we are using bell buckles a lot, but this was one case we did not use it.
Because as I mentioned, this is not very common, but like in the literature also probably about a couple of cases what is reported. So I'm trying to figure out what could have been the reasons. Because I have used BBG dye in the subretinal space to identify a break.
Yeah, we've also used in certain to identify, because there was a patient post-op who had laser marks who couldn't see where the break was. We injected sub and it's come out, and that patient is fine, but then this patient, so it doesn't make sense.
So
avoiding this subcon, just off the thing, I mean, all senior people are your opinion on whether we should use subconjunctival antibiotics at end of surgery or not. What is your
I don't
take?
use any antibiotic. I put topical antibiotic.
I think
that's all. Particularly what happens is like with the sutureless surgery, sometimes there is a hypotony. My thought process whether something goes into the eyes.
With the MIVS, we always worried about that. Earlier it was all sutured, so we were. And so the second thing which you mentioned was, yes, I think even the Egyptian groups, they showed that you put PFCL, then you need to use a much smaller quantity of the blue dye also, inject the blue dye at the interface of the PFCL and under the retina, and then peel under PF. So
yeah,
that is
I have done that. Only thing we need to be cautious about injecting between the PFCL and the retina is sometimes like how the depth perception is altered because of the convex bubble, and there's a parallax which is created. So we have to just about touch the retina and inject very gently. Otherwise, the dye can go through the retina into subretinal space also. So we have to be a little careful in doing this step. That's how it is.
Thank you.
We have a comment.
Yeah, so good presentation. I think I came in probably end part of your presentation, but we recently had two fellows who had operated and they had restained with brilliant blue, but they were routine case of macular hole. They didn't have any retinal detachment, so it didn't go subretinal. But it's a prolonged surgery of 20 minutes or more of ILM peeling combined with your stain, which can cause a combination. It's not just the dye alone, it's not just the light alone, but it's a combination. And the toxicity is much beyond the ILM peel. So there has to be some insult.
And it's affecting the nasal side, yeah, what you're saying.
It has to be much more than, and it's light probably, if you keep the light pipe very close, that's where we operate. If you're not operating ingenuity, in ingenuity we operate 10%, you'll find illumination.
Yeah, this was not
ingenuity. You're close to 100% operating, for 20 minutes peeling ILM and close to the macula, you are probably going to face this again.
So now I would like to invite Dr. Vishali ma'am for her talk on expert tips in using intraoperative OCT and proportional reflux.
No. I'm just continuing with this. I'm not giving any talk with what? It's not moving. I just want to say double dye injection. Probably what happens is you have the detached retina and you have a large macular hole.
Yes.
So probably I would avoid injecting it twice.
Yes.
And as Raja said, it's more of a phototoxic damage combined with this. And maybe some of these patients have tendency to
Yes,
develop
yes.
it, because like Dr. Mahesh said, we don't see it very commonly. And I'll give you this example, which was not a long surgery. Now this lady came to us, and you know, we are crazy people. So she just underwent PPV with ERM peeling, and routine dye was used. It was not ingenuity and it was not prolonged surgery, but then see after the surgery. And the problem with us is it's a huge group, huge practice. So when after the surgery somebody saw that did not take into the consideration that patient had undergone surgery. It is an elderly lady showing some funny changes. So somewhere along the way somebody says, is it masquerade? Is it lymphoma? So, you know, it went in a very different direction altogether. Standing here and saying that, okay, we did surgery and this thing happened is not so easy, because there is no relationship that we were aware of, and this was the autofluorescence. So believe me, we had a diagnosis of Azor, we had all the diagnoses which we are famous for making, without thinking that this patient has actually undergone diagnostic, not diagnostic, a vitrectomy for ERM peeling. So this can be misleading. Why that ERM peeling has caused peripapillary changes, we do not know. Something we do not understand, but she underwent ICG, she underwent everything, you know. So we saw some dark spots also on ICG. So she went through a lot of investigation, and only message I want to give through this is be careful if you see these changes post-vitrectomy, because they could simply be toxicity. Thank you.
Thank you, ma'am. I think Dr. Manisha had to make a comment. Please, ma'am.
So that's a very interesting observation, but I just wanted to say that if you want to peel the ILM when you have a detached retina, another way of going about it is that you have drained the fluid by making a peripheral drainage retinotomy. So I was wanting to actually ask the Rais that why did you choose a retinotomy within the macular area? When you have an SRF extending, what I would usually prefer is make a peripheral drainage retinotomy, drain the fluid, restart your fluid infusion again, and you get enough counter pressure then from the retina to peel your ILM without using the PFCL. So in that way, you can actually avoid injecting the dye twice, and it goes off well.
So I think maybe we do that now. This case was done, I think, in early 2017. But the other thing which always worries me when we make a firstly, the RD was not even extending so periphery, it was more posterior pole localized, and even nasal retina was on, for example. Secondly, I was worried that if we make a very peripheral, would we leave a lot of fluid? And you know, especially in myopes and all, it's like a bowl, like a katori, you know. So if we are going to leave a lot of fluid with a macular hole RD, would that compromise the success of the surgery?
I mean, not so much in the periphery, but at least outside the arcade. I thought you had a pocket of
this is
fluid
within.
extending temporarily also.
We thought we were very clever. We're using the 39 gauge self-sealing thing, so we can go posterior, because we didn't anticipate all this would happen. So we thought we were using a very fine, which is, of course I did little laser around it for my own satisfaction, but theoretically you can even leave that without laser.
And the other
so that's
advantage,
why I did go and also that some people initially, of course, I mean, long ago we used to drain through the break itself. So I thought this is a lesser of the evil, making a small drainage.
and the other advantage you get is that if you've drained the SRF completely, you have lesser amount of the dye then going underneath the macular hole.
Yeah, definitely. Thank you.
Thank you, ma'am. Thank you, Dr. Darais. Now, I would like to invite Dr. Aniruddha to present his case on a case of a subretinal mass.
Very good morning. So my case is that of a 57-year-old lady who presents with blurring of vision in the right eye for the past 1 month. Now she's had history of conjunctivitis 2 weeks ago and was treated outside, but no systemic illness. The examination revealed a best corrected visual acuity of 618 in the right eye, and the lid and addenxa were normal, and there was no anterior segment inflammation, and there was no evidence of any vitreous inflammation. Now if you see the right eye clinical picture, you can appreciate that there is presence of a large orangish lesion with RP changes in the macula, which is involving the posterior pole of the right eye. And you can see that the media is very clear. There is no vitreous cells or vitreous exudates, and the disc appears normal. And the vessels also essentially appear normal at this point. The examination of the left eye is completely normal. The OCT reveals a very large choroidal mass without much overlying changes of the retina. You do have, right in the subfoveal area, you have an elevation there, possibly a small area of fluid. But essentially, the retina otherwise looks uninvolved, but you can see a very large choroidal mass. And if you do an OCT which is passing right through the center, you can see that the mass is almost 1500 microns, and it's a really large one. And the ultrasound also shows you this mass with a hypoechoic center, as you can see in this image here. The fluorescein angiography does not reveal much actually. There's not much leakage, and in the late phase there is mild hyperfluorescence which is very ill-defined in the macular area. And the ICG shows you a hypo area which persists in the late phase. So at this point, this is the ICG here, again a close view, and the fluorescein showing you few stippled areas of hyperfluorescence. The fluorescein of the left eye is within normal limits. So the question here is, I advised an MRI orbit, but there are no masked lesions here. So the question is, where did I go wrong in advising an MRI orbit? Is it really a mass that I'm looking at? Is it a choroidal metastasis? It is an orange lesion. It is minimally hyper on fluorescein. The OCT does show a large choroidal mass, but is it not metastatic? Is it not malignant? So really this patient was given steroids, and this patient was given oral steroids, 60 milligrams per day, and she was much better with this therapy. And actually within 10 days this patient is now 6'6", and you can see this mass, which is actually a choroidal granuloma, has reduced in size. And you can see here that the EDI image is also showing you a reduction in the height of the choroidal mass. And 2 weeks later, the fundus photograph is showing you a decrease in the size of the choroidal lesion. And the OCT again is much better. Now you have a very much reduced choroidal granuloma there, and the retinal continuity, the regularity is coming back. 3 weeks later, it's still better. And you can see in the accompanying infrared image, the mass is also much decreased in size, and you can see that there are some RP changes on the accompanying infrared image, and 4 weeks later the choroid looks further improved. 4 months later, you can see that the choroid is now near normal, and you can see that there are certain changes in the photoreceptors in the outer segment on the OCT, but essentially it completely looks normal. So from diagnosis of really a choroidal mass where we were considering metastasis or malignancy, we have now come down to the correct diagnosis of a choroidal granuloma, and that is what is, I think, very important for us to understand. So with this, I would like to invite Dr. Shanmugam's comments on diagnosing choroidal masses in these patients and how you essentially differentiate them from choroidal granulomas.
As far as the MRI is concerned, I think it was necessary, except for the fact I would have advised MRI of the eyes as well as the brain, because one of the differential diagnoses I would have considered is a lymphoma. Because orangish lesions posterior pole involving the peripapillary region could be a lymphoma in this particular age group. So that would be one of the reasons, one of the things like why. But like why would we want an MRI is because this what you're looking at is a primary intraocular lymphoma, which is associated with CNS lymphoma. So in which case an MRI of the brain as well as actually the central nervous system is what is required, but at least an MRI of the brain along with the eye would be what is required rather than just an orbital MRI. The other differential diagnosis I was considering when I looked at the case is if it is a posterior scleritis. Because posterior scleritis can present without pain, and patient appeared probably to have some kind of an anti-segment inflammation, which is what was treated as conjunctivitis 2 weeks before the patient presented. So posterior scleritis would also be a differential diagnosis for me, and which probably resolved with steroids as well. And the FFA features is almost like that. It doesn't leak profusely, but some amount of that is also there. So to see metastasis, why I would not consider metastasis the primary thing is like mets usually presents with a lot of exudation. So there's hardly any exudation in here except for a minimal amount of fluid. So any small mets also presents with a disproportionately large amount of subretinal fluid. So that would be the reason why I would not consider that as the primary diagnosis. So it would be either a postscleritis or a lymphoma or probably a granuloma would be my initial diagnosis. And whenever I have doubts, yes, I would put them on an empirical treatment of steroids for about a week to see. And lymphoma also sometimes can get better, but then like the rapidness with which it gets better indicates what could be the diagnosis.
So you did mention that you would like to put certain patients on empirical treatment with steroids. So while your patient is on the empirical therapy, what are you looking at? Do you ask for certain laboratory tests, or do you ask for certain imaging features that you would like to see during this time?
If the suspicion of lymphoma is very high on the list, then of course I would not put them on empirical treatment. I would investigate them, have an imaging done, and subsequently if I rule out lymphoma, then I would probably put them on empirical steroid treatment. Steroids is when I would probably suspect a posterior scleritis to be much high on the list. Other thing is an infective granuloma. If it's an infective granuloma, once again I would not put the patient primarily on steroids, which the infective granuloma usually does involve the retina and some amount of vitreous inflammation would be there, in which case sometimes it would be an empirical antibiotic and subsequently a steroid. So only if the mass lesion looks inflammatory and probably doubtful lymphoma, and after the imaging I would probably put them on an empirical steroid.
Thank you, sir. With this, I would like to invite Dr. Vishali ma'am on this side of the podium, please. I'm on this side of the podium, please. She'll give her expert comments on diagnosis of choroidal granulomas.
Right now, we are between the differentials of lymphoma, posterior scleritis, and infective. Lymphoma, I will not consider as the first differential if it is primarily involving the choroid, because it is primarily when we see the lymphoma, at least in our experience, primary vitreoretinal lymphomas, they produce subretinal precipitates, and you see the bumpy RPE. Now, what Aniruddha showed was primarily the lesion in the granuloma. Now, the second two which are left is posterior scleritis. I absolutely agree this could be posterior scleritis because it is unilateral. It is pushing the choroid and everything forward, and we also have those pinpoint spots. So I think it is important the next time we see these patients, we get an ultrasound done to look for T sign. The third, when I saw those pinpoint spots on fluorescein, I said, is it VKH? But it is unilateral and it is not really behaving like VKH on response to therapy. So the job Aniruddha gave me is, how would you know? And Dr. Shangaman said that you have to know whether it is infective or non-infective before you start empirical therapy. So what are the pointers that it could be infective? Number one, you are seeing cells and flare in the anterior chamber. Number two, you are seeing cells in the vitreous. And when we are talking of granulomas, we are basically talking of TB versus sarcoid. Now, how do you differentiate the two? If you look at it, TB is a process which is driven by VEGF, and all the experimental models of TB have shown that your VEGF will go up if it is a TB granuloma. Now, if you see these lesions, hemorrhages, which we very fondly call RAP, think of TB as a possibility. It's very strongly going to be TB because sarcoid granulomas do not produce these new vascular lesions, or these RAP are hemorrhages. This is another example of TB granuloma. Now, this is again a granuloma, and it is producing a lot of exudation. But again, I would like to draw your attention to this small little hemorrhages on top of it. So the moment you see a RAP with a granuloma, always rule out tuberculosis. And if you have to give empiric therapy, anti-VEGF is the empiric therapy, because these granulomas respond extremely well to anti-VEGF therapy, and sometimes you will even see them decreasing. However, if it is TB positive, you would like to add anti-TB drugs to, take care of the future recurrences. Look, pay attention to the kind of the OCT, because lymphomas are going to have sub-RP deposits, metastasis, Dr. Mahesh said beautifully, will have a lot more exudation than you would suspect. TB and sarcoid would have a focal elevation, and VKH will have the stromal diffuse kind of infiltration. They will not produce a focal bump like this, and you can see this responding to bevacizumab followed by prednisolone. I don't think I have time to show a case, so we will take up questions from the house because it is an interactive session.
So at this point, I would like to invite any questions from the audience if you have any questions. While I invite Dr. Jayesh Sheth to set up his next talk, a case on what is the etiology of subretinal fluid.
This is for Vishali ma'am. Ma'am said that B-scan ultrasound has to be done for such cases, but ultrasound was already done, ma'am, in which there was no T sign.
You did? I missed that.
Yes, in the previous case, we did have an ultrasound which showed a hypoechoic center without a T cell.
That kind of goes against posterior scleritis, but as they say, nothing is 100%, Ultrasound, again in our institute, depends who did it and what mood he was before reporting,
Thank you.
So, good morning everyone. Thank you Aniruddha for giving me this opportunity to present few of the complications that I have made till date. So, this was an interesting case of a 59-year-old lady who presented with, to me with left eye. Can we have slides? Yeah. So, who presented with left eye decrease of vision since 1 month. Her vision was 6/36, whereas in the right eye it was 6, 6 and 6. So this is the fundus photo of the patient. So right eye was essentially normal. In the left eye there was presence of a serous macular detachment in at the posterior pole area with few pigmentary changes that were present in this location. So the right eye was fine, including the ICG, the fluorescein angiography and the OCT. We'll be focusing on the left eye. So here we see there was presence of, this confirms the presence of a serous macular detachment with presence of underlying dilated choroidal vessels were present. A very shallow pigment epithelial detachment was also noted in this location with minimal hyperreflectivity that was there inside. We went ahead and did an fluorescein angiography and an ICG. The FFA did not reveal much changes. It was just more like a window defects that were present in that location. And the ICG also showed very suspicious plaque kind of lesion in that location. So I came with a working diagnosis of maybe it is like a resolving CSR. So I put the patient on conservative management and started on oral epiretinal 50 milligrams with topical naproxen eye drops. So 1 month later, she showed good response with a reduction in the SMD and an improvement in the vision. And 2 months later also she improved to 6/24 with the SRF resolving almost completely. However, 3 months later, she again came with worsening of the fluid in that area, and there was an increase in this irregular PED size with presence of underlying dilated vessels. So I repeated an ICG for the patient again, but which did not reveal much changes, just that plaque kind of lesion was there at that location. So now I went ahead and did an OCT angiography for the patient, and which revealed a suspicious underlying network. So maybe this was corresponding to that shallow irregular PED that was there on the OCT. So this is just the multimodal imaging put together. And then when I went and looked back into the ICG image, I zoomed in and there was a very suspicious network that was there in this area that corresponded to the OCT angio network. So for this patient, I treated the patient with a photodynamic therapy and a single dose of intravitreal ranibizumab, and there was a significant improvement in SMD and the network completely resolved on this. And 3 months later, the vision acuity of the patient started improving, but the network again started coming back, but there was absence of any fluid. And 14 months later, again the vision started improving even further. She improved to 6/24, but the network is keeping on increasing. Those fine vascular things can also be seen at that location. So just for the point of discussion is, was the CNVM missed at baseline? And there was definite improvement in the vision as well as the SMD over a period of 3 months. So, or was it just a CSCR to start with? And should OCT angio be done for all suspected networks? And if there is a quiescent network, what should be the way forward? Thank you.
Thank you, Jay. So if there are any questions from the audience at this point, well, I would like to invite Dr. Vishali Gupta for telling us the expert tips on how to diagnose CNV on OCTA. Yes, there's a question, please.
I just want to know your criteria for PDT in such cases, or monotherapy would suffice, and how do you combine the two treatments? What are the criteria?
Yeah, so we came with a working diagnosis of a pachychoroid neovasculopathy, and there were presence of underlying dilated choroidal vessels. So if you go by literature, PDT works the best for these patients, because just giving an anti-VEGF, the networks are usually very less responsive to injection. So PDT is the way forward. So along with that, we combine it with a dose of an anti-VEGF. So that is how it responds. Quite.
The approximate cutoff pachychoroid, how do you decide? What do you take? How much is thickness?
See, yeah. So there is no specific cutoff, because there are various studies which have very different cutoffs for pachychoroid. Few of the studies, they mention more than 200. There are few studies who mention more than 278. So it is not just the presence of a pachychoroid or a thick choroid. There has to be underlying changes of like RP irregularities, or even a focal pachy vessel with an overlying compression of the choriocapillaries with an overlying RP changes. That there are particular, these are the definitions where you can include the patient in a pachychoroid. Yeah. Can we have the
Can we
slides?
have the slides of podium 1, please? Yes.
Yeah. So we can, So here we can see large dilated choroidal vessels with an overlying compression of the choriocapillaries. And usually all these networks, like this was a suspicious network, so they usually overlie the area of focal pachy vessels. So this is how a pachychoroid typically looks like.
So I think the components of pachychoroid, just to emphasize once again, you will have dilated choroidal vessels, overlying choriocapillaries compromise or ischemia, and if you do an ICG, you will have choroidal vascular hyperpermeability. So if you go to the ICG here, you can see in the late phase, the vessels are slightly blurry and hyperpermeable.
This, yeah.
These vessels are typically coursing through right to the macula. Sir, as a comment, please.
Yeah, so the choroidal vascular hyperpermeability, even those two away from the macula.
Yeah, these two spots.
You will see them nasal to the disc, you will see in the other eye. Even if the other eye is 6/6, you will see this in a pachychoroid disease. But then the double layer sign, you see the elevation of RP from the Brooks membrane is very, very typical. Then that's when you should suspect an incipient net, or even if there is a fluid, do an OCT angiography, it can pick up very nicely. In fact, better than the ICG. But then the question which comes is, when you have a pachychoroid disease and you have the CNV, I mean, you may have easily missed it, and there's so much fluid on top of that. In a routine CNVM, let's say macular degeneration or myopic CNVM, any other disease, the CNVM would be larger, but the fluid will not be as much. So the problem which comes is, you find a CNVM and you see that it's a pachychoroid disease, but you are now confused, the fluid is because of CNVM, or is it just choriocapillaries leak? The choriocapillaries compression is a very important point. It's not just the cutoff, and you need to have the compression of choriocapillaries. But then what do you do next? You have a CNVM, you have on ICG vascular hyperpermeability, but in general, what Jayesh has said, that they don't respond very well to anti-VEGF in these. Even if the CNVM activity is there, its contribution is much less than the pachychoroid itself. You do the PDT, it resolves, and even after the resolution, you see this net was still there, but there's no fluid. So the activity of the CNVM is not much, and then you keep on giving anti-VEGF in just a pachychoroid disease, it doesn't respond very well. So PDT is the usual way to go for this.
So, and how would you follow up these patients with the quiescent network?
Follow up in the sense how often kind of thing?
Yeah.
Maybe once in 3 months
Okay.
as such, but then what we would definitely do is if there is a recurrence, that's again the confusion may start as to whether it's because of the CNVM activity or pachychoroid hyperpermeability. You will have to just not depend on OCT, you will have to repeat an ICG if there is a recurrence of fluid.
Okay. Thank you.
Thank you, sir. Thank you, Jay. Ma'am, please.
I think my discussions all got preponed because I have to go and others, so you won't be seeing me after this, don't get. Another thing is when you are thinking of CNVMs, the mistake we make, like pachychoroid, is a patient of choroiditis. For example, this lady, now she's a very young girl and she says, now I am symptomatic and I'm having metamorphopsia. So, you know, you look at it and you say, oh, everything is scarred, nothing much happening. And I first thought probably there was some extension of the scars into the fovea, and that was the reason for her recent symptoms. You do OCT, and she had received treatment for TB choroiditis earlier and steroids also, but you see something like this, which is called SHREM, or even if we don't call it SHREM, there is some hyperreflectivity going on, and you are not sure, is it the scarring of choroiditis, or is there something happening underlying? You do all sort of investigations, but it's, you know, there is so much happening in a choroiditis eye that it is very difficult to pick up an underlying new vascular network. And here is the OCT angio, which shows a beautiful underlying new vascular network under this. Now, the question which was being discussed before I came here between Jay and Raja was, how would you follow these patients? To me, the symptoms are the most important. If this network was there and my patient was not complaining and her vision was stable, I would just not go on injecting because it is present. But the day patient complains of something will be the day when I would inject if there is no fluid on OCT and you are looking at these new vessels only on angio-OCT. We are in the process of characterizing the active from inactive, but for all clinical purposes, we have not yet reached the stage where we can see that we are seeing the new vessels, so just inject. This is how it was. We realized if we were injecting, the vessels were going better, there was pruning, and if we would extend the interval, the vessels would kind of come back. So this girl we have almost for 2 years now follow-up, and it is PRN basis. So I think the moral of the story for this mistake is that sometimes you have a choroidal neovascular membrane which may be complicating an underlying disease. Jay showed you a patient of choroiditis. Patient of pachychoroid. I have shown you patient of choroiditis, and there are a lot of publications, including from Dr. Reema Bansal from us, chronic CSC. Chronic CSC, now with the angio-OCT, we are seeing a lot of new vessels which are lurking beneath, which will respond to anti-VEGF. If you are seeing choroiditis and new vessels, it will respond to anti-VEGF. But if you are seeing pachychoroid and new vasculopathy, it will respond to PDT. So that is why it is important to know what is happening underneath.
Thank you, ma'am.
Now I would like to invite Dr. Raja to give his comments on should we treat a CNV on Octa with no fluid.
Are there any questions from the audience while sir is setting up?
So any questions from the audience? Yes.
For
For these inflammatory CNVs, is there any role of anti-inflammatories? I mean, injection, like steroid or along with the anti-VEGF?
A lot of these tuberculous granulomas, they do have a VEGF component in them. So nowadays, there is a protocol that they should be treated with an intravitreal anti-VEGF also, because they are usually very vascular. So there are certain features that are seen on an fluorescein angiography and an ICG, which reveals their vascular nature. So they do respond very well to anti-VEGF, along with giving oral steroids and starting the patient on anti-tuberculous treatment.
No, the case which madam showed here. So just anti-VEGF would suffice, or you need to inject steroids also?
So typically these patients would have a quiescent disease, and a CNV would develop long after the active choroiditis has healed. So if your ICG is not showing you any active lesion, you would typically just treat with anti-VEGF and follow these patients on PRN basis. And at some point, if you do develop active disease, only then you would treat with anti-inflammatory and ATT.
Thank you.
Yes, sorry, my slides have not been uploaded, but typically if the question is, when we see a CNV but there's no fluid on a structural OCT or a B scan, at this point of time we are not treating them in general, so unless there is fluid. So because these nets, what we have seen from multiple studies or long follow-ups, is that the CNVM by itself never goes away completely, at least the macular degeneration, those under the RP. So a part of the CNVM which is above the RP may kind of go away with anti-VEGF treatment, but the overall mature vascular network of choroidal neovascular membrane, it stays on lifelong. So the point is, only if the disease is active you need to inject, and that is based on the regular OCT scans. So a lot of this now translates into a big question for a lot of ophthalmologists, that you see a lot of OCT angiography in various conferences, much more expensive than a regular OCT. Should I just now go on to buy an OCTA to improve my practice decisions? At this point of time, OCT angiography is useful to identify a net, but OCT is the real decision maker for you. The regular OCT, which we already have, let's say stratus or even spectral domain OCT. So if you have just fluid, that's the deciding factor for making decisions on retreatment. So at this point of time, we are not treating CNVs just because they are on OCT angiography and there's no fluid.
Thank you, sir. Any questions from the audience at this time? Yes.
Raja, do you think there's a difference, any difference in the role between the anti-VEGF agents for treating pachychoroid-driven neovasculopathy, like type 1 CNVMs? The reason I ask is we had a case who didn't do well with the regular anti-VEGF, with bevacizumab. We switched to aflibercept, in fact, and showed a case in the previous session. The fluid went. So do you think there's the molecule, changing the molecule would help? And these are the patients then we don't need to do PDT for?
So at this time, for me, the experience has been that with CSR, if there is a CNVM, I definitely counsel the patients for PDT right away, because in my experience, unless the CNVM has come into above the RP, which is extremely uncommon, but if it's below the RP, they hardly respond to any anti-VEGF, even if you give aflibercept. But yes, if you look at the molecular size, bevacizumab is 150, so it probably will have least penetration. Then you have aflibercept about 100, and then you have ranibizumab at around 49 or 50. So that way, the smaller the molecule size, better may be the penetration. But it's theory. At this point of time, I don't know if there is any better answer.
But would a combination do best for this? Would you give anti-VEGF plus PDT or only the PDT?
Yes. No, anti-VEGF with PDT. In fact, some of the patients who cannot afford PDT, because if I say PDT, how many patients can afford PDT? What's the next best alternative? So I have micropulse laser. I do 5% micropulse paint over the CNVM area, just like you cover with the PDT. So that's one alternative that you can have. Or TTT is one alternative.
Thank you.
And So do you prefer full fluence PDT or a reduced fluence?
In
So how do you-
pachychoroid disease, I prefer reduced fluence speed.
Reduced fluence.
They are younger patients, they're likely to have RP damage.
Okay. Thank you.
Thank you.
So now we'll have the keynote address by Dr. Anton Kolesnik. He'll be giving his talk on clinical and morphological outcomes of early idiopathic epiretinal membrane surgery. Dr. Anton is a research worker of vitreoretinal pathology department at S. Fodorov Eye Microsurgical at Moscow. And his scientific interests include anatomical, morphological and functional features of new approach in vitreomacular pathology treatment, new methods of IOL repositioning, retinal detachments, treatment using gas tamponade in case of inferior detachments, and uveitic. Over to you, sir.
Good afternoon. Idiopathic epiretinal membranes are contractible fibrovascular membranes that occur on the surface of the retina, causing tangential forces leading to a deformation of the retinal architecture and significant visual impairment. IRM consists of different cell types, including glial cells, hyalocytes, retinal pigment epithelium cells, fibroblasts, and myofibroblasts and extracellular matrix components. The importance in IRM development is, as the different studies showing, is that retinal Müller and other cells in the presence of certain pro-fibrotic cytokines can transdifferentiate into a myofibroblast-like phenotype and start to produce smooth muscle actin, alpha-SM actin, and induce tissue contraction. The distortion of the retinal surface due to IRM contraction, which in some cases can involve the entire retinal thickness, is the primary cause of metamorphopsia, which is usually the leading and most disturbing symptom of the disease. Surgical removal of ERMILM is usually performed using a 25-27 gauge vitrectomy. During surgery, both the ERM and the ELM must be removed from the retina surface in order to release the traction on the macula. Surgery for IRM improves or stabilizes visual acuity, decrease metamorphopsia, and restore macular anatomy. Nevertheless, patients with low preoperative visual acuity do not enjoy completely recovery after membrane removal. Limited restoration of the visual acuity in these patients can be due to chronic retinal tractions, leakage, vascular leakage, and persistent cystoid macular edema. All these facts restricts the restoration of macular anatomy and function. The purpose is to investigate the functional, structural, and morphological outcomes of ERM surgical treatment in different proliferation phase. All patients were 60 eyes of 60 patients who underwent 25 gauge pars plana vitrectomy were evaluated in this study in 1, 3, 6, 12, and 24 months after surgery. And all patients were divided into 3 groups depending on visual acuity. And the present study evaluate flat-mounted ERM surgical specimens for evidence of presence of different type cells transdifferentiations. Retinal Müller cells, astrocytes, hyalocytes expressing glial acid fibrillary protein, GFAP. This is a marker of cell activation. Vimentin, CD45, self-expiring alpha-SM actin, that is myofibroblast marker, and type 2, 4, and 6 collagens. We want to demonstrate ERM and ELM removal features in different groups of patients. All the membrane in first groups were removed separately from the ELM. After dual blue staining, first create an ERM flap with 25 gauge forceps and peel off the ERM as a large whole piece passing through the fovea. After that, we performed macular axis ELM peeling. In the second group, all membranes were removed as a single block with ILM, And you can see it clearly because of the epidesis on the retinal surface. It's quite impossible to remove this type of membranes separately from ILM because of a really strong adhesion, even in this group of patients. In third group, we revealed strong membrane adhesions to ILM, sometimes in the fovea, and they were removed in a unique single block also, trying to minimize tractional forces on the macula, and sometimes performed vitrectomy around remodeling tissues. And also we perform a double staining to make sure of complete ILM removal. All surgically removed ERM of first group specimens were found to have positive immunostaining for glial fibrillary exit protein, GFAP. Also CD45, immuntin, and cellular retinal degate binding protein, indicating the presence of glial cells and hyalocytes in the membranes. We also observed an alpha-SM positive cells in 12 samples. They were transdifferentiated from retinal Muller cells and astrocytes into a myofibral blast-like phenotype. They start to produce a smooth muscle actin and induce tissue contraction. And in this case, symptomatic patients start to complain of decreased visual acuity and metamorphopsia. In second group, we revealed progressive increasing myofibroblast-like cells that is responsible for the upregulation of type 2, 4, and 6 collagens, also CD45 positive hyalocytes, and reduction GFAP positive cells. We concluded that the alpha-SM actin expressing transdifferentiated retinal Muller and other cells, which represents myofibroblast-like cells, are responsible for the membrane contraction. In the same time, we revealed that in the ERM accumulate more and more extracellular matrix components, resulting in the macular reorganization. In third group membranes, we representative of extracellular matrix component combinations, 4 and 6 collagens, little activated hyalocytes, and alpha-SM actin positive cells. This membrane had strong adhesion to ILM and were removed also in unique block during vitrectomy. We didn't observe any Muller cells or astrocytes in this type of membranes. In the current study, we showed that progression of IRM can be considered as a proliferative fibrotic process with collagen deposition and further membrane contraction. Increased expression of the transforming growth factors induces the differentiation of different cells into myofibroblasts, granting IRM their contractive properties. In the IRM represent a complex network containing many types of collagens. These membranes have a strong adhesion to the ILM that leads to difficulties during membrane peeling, extra tension on retinal nerve fibers damage. An improvement of postoperative best-corrected visual acuity, as well as a statistically significant central foveal thickness reduction, was observed in all groups, maximum after 1 year of observation. Postoperative best-corrected visual acuity was significantly better in patients with group preoperative, with high visual acuity preoperative. In comparison between three groups, it was found that there was a significant improvement on visual acuity and central foveal thickness in first group. These patients have very little macular damage during surgery, resulting in good recovery of the macular function. The postoperative ESOS alterations and macular edema were significantly higher in second and third groups. On this basis, it could be concluded the membrane thickening and contraction due to cellular transformation leads to distortion in the external and internal retinal layers, resulting in non-reversible anatomical changes, which conventional removal of the ERM and the LM on the late stages may cause additional surgical trauma. That is why an early intervention prior to the induction of permanent damage seems more rational for better visual outcomes. And connecting to the name of this session, the main mistake, I suppose, is waiting for visual acuity loss. So early intervention gives better results. Thank you very much.
Thank you. So with this, I'd like to invite Dr. Jay, who will be presenting his the fourth case of the session. So this is a unique case of choroiditis, which is mimicking CSC. Dr. Jay, please.
Yeah, thank you. Can we have the slides, please? Yeah. So this is a confusing case of choroidal disease. Yeah. So this was a 32-year-old male patient who presented with sudden onset of painless blurriness of vision in the right eye for 1 day. He was a known case of hypertension and a chronic smoker. His visual acuity in the right eye was 6/24, whereas left eye was 6/6. He had a normal anterior segment and normal intraocular pressures. So this was the fundus photo of the right eye. So there was presence of a serous macular detachment that was seen at the posterior pole area with tracking of the fluid slightly in the inferior segment also. There were few yellowish lesions were seen in this location, what we can see. And this is the multicolor image and the fundus autofluorescence. And this shows a very suspicious track mark kind of thing in that location. So we went, and this is the OCT. The OCT showed presence of a serous macular detachment in the inferior sections, whereas in the foveal section there was kind of a bacillary detachment was seen instead of the classic serous macular detachment. On fluorescein angiography, there were very few hypolesions were seen that corresponded to the yellowish lesions that were seen clinically, and very suspicious leaking points were there in this inferior location, and pooling was seen in late phases. There was minimal disc leak in the temporal quadrant that gives us a suspicion of some kind of inflammatory pathology that is going on. The ICG showed, the early and the late phase of ICG showed presence of these hypolesions that were there throughout the macular location. The fluorescein angiography of the left eye was unremarkable. So what makes it look like a CSE? So there is pachychoroid on OCT. There was subretinal fluid, especially in the inferior sections. There was pooling of the dye on fluorescein angiography with suspicious hyper dots. ICD showed presence of large vessels and a suspicious inferior track mark on fundus autofluorescence. So this can be easily confused with a case of CSR. And why is it not? Because the presence of a thick choroid does not only is present in cases of CSC, but there is an expanded spectrum, including choroiditis can have these kind of features. The OCT showed a bacillary detachment. There were no definite leaking points on angio. The ICD showed hypolesions both in early and late phase, and fundus autofluorescence changes of those track marks can be present in multiple conditions and not just CSCR. So we did an investigation for the patient, and MAN2 was very positive with 13/13 millimeters. However, the quantiferon TB gold was negative. We started the patient on empirical oral steroids, and the lesion started healing within 1 week, and within 1 month the patient became absolutely normal. The visual acuity improved to 6/6 N6. So this is the fundus photo, and this is the OCT, which became absolutely fine. Now the disease was almost quiescent for 2 years, and the patient presented last month again with a reduction of vision in the same eye, with vision acuity again dropping to 6/24. Now this is the fundus photo again. Now those yellowish lesions are seen very much more clear at the current visit as compared to 2 years back, and there was suspicious lesion even in the peripapillary location. Now this is the OCT, which shows presence of a serous macular detachment, and there is a choroidal lesion can be seen in the peripapillary area. So this is suspicious of a granuloma. Now the patient had a positive Mantoux test, and of course we repeated the ICG also, which again confirmed the presence of those hypo lesions in this location, and the fluorescein angiography again showed pooling in that area. Now FFA of the left eye and ICD was normal. So we came with a working diagnosis of a tuberculous granuloma since the Mantoux was positive, and since these lesions are known to be vascular, so we planned the patient for left eye injection ranibizumab along with giving oral steroids and starting the patient on anti-tuberculous treatment. So he received the injection on 17th of January, and we started the patient on 50 milligrams. So 1 week later, there was a reduction in the horizontal extent of the SRF and minimal reduction in the granulomatous lesion also. Thank you.
So here actually if you see, Jay, in your patient, the patient when he presented the second time had much more classic presentation of a choroidal granuloma. But if you look at the initial presentation, especially this OCT scans of the inferior part, you can actually confuse it for the CSC.
Can we have the slides, please? Yeah.
If you just look at the OCT at the bottom, that just looks like a CSC. And even if you look at the fluorescein angiography, at the late phase, there's pooling of the dye just like you have
like
it in a patient of a CSC. I think the ICG was really important here because in the ICG you find the persistent hypo to hypo lesion, which indicates presence of active choroidal granuloma.
Exactly.
Also the OCT image passing through the macula is showing you what is called as the bacillary layer detachment, which is basically the detachment of the outer photoreceptor layer, and that is indicative of pathology which is inflammatory. So if you go back to the OCT actually.
Yeah.
The OCT right on top.
Yeah, so this is the...
The remnants of photoreceptors are seen at the bottom, and you have a hyperreflective line which is almost forming like a cyst, you know, in the central OCT. And that's what is called as the bacillary layer detachment, which is very classic of VKH or other inflammatory pathologies. Any questions from the audience, please?
If I see the initial presentation of this case, I would have rather kept a VKH as a DD rather than a CSC. And because you have a hot disk, you are seeing those hypofluorescent areas which are suggestive of some inflammatory granulomas. So I would not be very convinced to keep a CSC as a differential. Yes, I do agree, I would have got confused because you do have a pachychoroid and you do have, like you have a thickened choroid, you have an inflammatory element there.
Yeah.
So I would have got confused with VKH, but started patient on steroids as you also did, and the patient responded well.
Very true. I think, and nowadays we are seeing VKH which are unilateral. We have seen at least around 10 to 15 patients of VKH which present unilaterally. So, as ma'am said, that is an important differential diagnosis in this case. Agreed.
So the OCT itself, it's highly unlikely of a CSR. To me, the question of pachychoroid is not about the thickness at all. If you have an intact choriocapillaris layer and a saddler layer, there's no compression, you just don't entertain a diagnosis of CSR. I mean, unless you have to obviously look at all the scans. Just based on one scan, you can't rule out compression of choriocapillaris. But if on all the scans there is no compression of the choriocapillaris, you are not dealing with CSR. Obviously, the bacillary detachment takes it away from CSR, and ICG, I use it many times to rule out CSR. And this ICG has definitely ruled out CSR, but there are no signs on OCT either.
So your slides
such types of unilateral presentations are very common after application of hair dyes. These are usually unilateral, and as against the VKS, there is no recurrence at all. One time occurrence, and when patient repeatedly apply the hair dye, again it appears.
Thank you.
Thank you, Jay. Dr. Raja's slides are here, so we'll just go ahead and... Can you switch on the mic here?
wanted to share an interesting case where the patient was presumed to have a CNVM, but the etiology was not mentioned earlier. This patient came for an opinion himself. Patient had poor vision in one eye for many years, and the left eye, he just had a recent drop in vision, about 4 to 6 months. And he had gone to another eye center and he had got 2 intravitreal injections. At that time it was, he had received Lucentis injection in the left eye and there was no improvement, so the patient came to us. So there's you can see a scar here and you can see a yellowish lesion on this side in the left eye. And the OCT at this point of time, for at least for general ophthalmologists, for us retina people, we are used to name changes or new names coming up every few months and trying to understand what it is. But if for general ophthalmologists, you don't have to worry as long as your basics are correct. If you see something subretinal high reflective, does not necessarily mean that it's a CNVM. In a CNVM, the choroid, the RP has to be disrupted even if it comes into the subretinal space that is above the RPE. So in this patient, you have a high reflective subretinal lesion, you have some fluid, but overall the RP here is quite intact, maybe some double layer sign which is forming over here. But since this patient had also not improved after 2 injections, we definitely, I mean demographically this patient, I would say that I had a very high suspicion of CSR. This patient was from West Bengal. But then the right eye obviously was not very typical of that, all the pigmented scar, but you can have in some cases. We did an FA, you see that ink blot leak over here, very nice. And then you see the choroidal vascular hyperpermeability, which was shown in the earlier cases also. Whenever you see a diffuse choroidal vascular hyperpermeability in patches, that is highly suggestive of CSR. And the CSR leak, in fact, is shown very well on ICG also. We are all used to learning during our PG that FA is good for retinal diseases and the leak is less in ICG. But in CSR, a typical CSR leak, whether it's ink blot or smokestack, is very well seen on ICG also, as in this one here. We went ahead with laser, focal laser, because quite close to the FAZ using Navilas laser. And this is the photograph comparing the pre and post laser. So patient came to us with already 2 anti-VEGF injections. This is how it was. And after 1 laser and 2 months, no further injections, this fibrin has disappeared, there's no fluid now. So this was a case of CSR with no CNVM. Although if this was a time when we did not have OCTA, but if we had done an OCTA and looked at this double layer sign, maybe something may have shown up, we may have been worried about an CNVM and may have injected. But yes, the main pathology was CSR and we did laser, it disappeared. So this is just to compare the FA and ICG of a CSR patient. You see in the right eye also, while the left eye is showing a nice ink blot leak, the leak is very prominent on ICG too. So ICG leaks very well in CSR. But the right eye, which was normal, also is showing choroidal vascular hyperpermeability patches, which is extremely important to know in CSR. And if you do autofluorescence, you'll find changes in that too. The advantage of FA and ICG versus OCTA is that in OCTA, because it's dye-less, it cannot pick up any leak. It can pick up flow areas of blood vessel, new vessel formation, but any dye leakage because of either outer blood retinal barrier leakage or inner blood retinal barrier leakage, you need FA or CSR. So these are some of the points I just wanted to touch on. You cannot forget or remove FA and ICG from our practice at this point of time. Thank you very much.
Thank you, sir. Any questions from the audience? I would like to also invite Dr. Atul Kumar, sir, who will be discussing few pearls on when one should use ICG and OCT angiography in CSE choroiditis. We can take 1 or 2 questions from the audience meanwhile. I think what the cases really show is the importance of the choroidal vascular hyperpermeability And I think that's a very important feature that you can see on the ICG, and you should not just focus on the thickness of the choroid. There is no cutoff value really to tell you that this is a pachychoroid, but there are a couple of important elements. One is the choriocapillaries ischemia and the choroidal vascular hyperpermeability on the ICG. Yesterday we also discussed the importance of vortex vein imaging in ICG, and you can actually see the vortex vein engorgement in patients who have pachychoroid disease. And this can be imaged on wide field ICG, and the presence of vortex vein engorgement goes also in favor of pachychoroid spectrum of disease.
Thank you so much for having invited me, Aniruddha, and it's a pleasure to be in your those mistakes, retinal mistakes which we make, and how to look at them, how we make those mistakes, and how to rectify them. So I'll also be discussing about OCT and ICG angiography in CSC and choroiditis. Mostly CSC I'll be talking. So. Now, we should know that OCTA measures the blood flow dependent on the vascular cell movement. That's basically those RBCs moving. While the FA-ICG is totally independent of the cell movement, it depends on the flow of the blood plasma. It has nothing to do with the cells. That's very important to understand between OCT A and ICG or FA. On OCT angiography in CSC, we observe, as we've already said, that there is a hypo and hyperperfusion. There's a motile fluorescence there on OCT angiography in the deeper layers as you cut the sections. And what has been seen is that there are many hot spots in late phase ICGA which are in close proximity to the ischemic areas on octa. So the octa hyperperfusion areas or decreased perfusion areas or low flow areas correspond to hot spots in ICGA. Hyperperfusion leads to increased, as you said, hydrostatic pressure. This is basically the pathogenesis of CSC within the fenestrated capillaries, and this increased hydrostatic pressure contributes to the leakage, the chronic hypoxic damage, and also to the disintegration of the RP and then to the fluid in the subretinal space, leading on to chronic CSC. So probably when we need to do is when the CSC starts becoming chronic, and you have areas of, there's a hot spot over there with motile fluorescence on ICGA. You see this hot spot over here, and there's a motile fluorescence. This hot spot usually corresponds to the area of low perfusion or decreased or ischemic area on the octa. So basically what I want to say is that this ischemic area is the hot spot, and that's the time probably when we can think of doing a low fluence PDT. And as has been said that besides other indications for getting an octa and ICGAs, in cases of chronic CSC, because they often are part of the pachychoroid spectrum, and pachychoroid spectrum on the other end leads to what is popularly known as polypoidal choroidal vasculopathy, which is very predominant in our country, which was probably not picked up because of we didn't have the kind of imaging techniques which we have now. And we are also looking at it more carefully. So Asian countries are more involved, and definitely India is one of them. And it's been seen in Japan, Singapore, other countries also, but India has also been picking up. And so we see this area of hyperfluorescence, a well-defined area, along with a lot of motile fluorescence, the case of chronic CSC over time. And then when you do the ICG, you can actually pick up the polyp, a very large polyp over there. And the polyp, sometimes the tiny polyps may not be picked up, but the octa also, besides ICG, the octa has also picked up the polyp. And these PDs correspond to some extent to the polyp, and you have this double layer sign, which is because of the branching vascular network. So getting a octa done as well as ICG can be a useful test for a case of chronic CSC, because you then have to intervene. There's fluid, subretinal fluid, there's double layer sign, there's presence of a polyp. All this will contribute to getting a anti-VEGF as probably as well as a low fluence PDT done. So this is another case of chronic CSC, which is actually on doing the ICG you pick up the lesion. So the role of ICG is immense, and FA-ICG can be done. The ICG picks up the polyps clearly, the FA doesn't do that. And you can see the branching vascular network also. So these multiple PEDs which are there, which are often said to be part of the lesion of the polyp and with subretinal fluid. And of course, so in serpiginous choroiditis, it is said that the presence of lesions in the choriocapillaries, that flow voids, what they say is that the AF imaging shows the activity. The autofluorescent imaging shows the activity of the choroiditis lesion, and it corresponds to the hyperfluorescence lesion, the hyperfluorescence of the low fluorescence lesion on the OCTA. So therefore, what they say is that choriocapillaries is the site of serpiginous choroiditis, is not RP. So because there is absence of RP lesions, so the choriocapillaries are getting affected in serpiginous choroiditis, which correspond to the AFI. So this is what I'd like to say, and this is an article published in Ophthalmology Retina. So CSC gets understood very well as the serpiginous choroiditis. There is an article also by the PGI group, Professor Vishali Gupta, Aniruddha and everybody, which also said that choriocapillaries are the primary site of affection in cases of serpiginous choroiditis. Thank you very much.
Thank you so much, sir. Any questions from the audience? No? Okay. So we move on to the last case of the morning. So I would like to invite Dr. Darius to present his case on pathological myopia.
Good morning, everyone. And so I'll be presenting my mistake in myopia. This is a 48-year-old lady who was a high myope in both eyes, minus 17.5 in right and minus 18.5 diopters in left, taking anti-glaucoma medicines. You can see the axial length is more than 30 millimeters in both eyes. Left eye, she underwent PDT in 2003, and in 2008 she had a vitrectomy for RD. So basically she's totally dependent on the right eye. Left eye has counting finger 1 meter vision. She came for a follow-up in 2018, at which time everything was fine and the OCT was stable. She came recently to our group in October, on 14th of October, and she said there's a lot of she's having some distortion in the right eye, which is the seeing eye. Vision was 6.6 N6, and so a routine OCT scan was done, and this printout was attached to the file, and you can see the OCT below was the one done in 2018. And you can see this is a recent OCT done in October, and everything looks fine. So we kept reassuring her, saying everything is okay, but she was unconvinced. She came back again on the 31st of the same month, within 2 weeks, and said, no, something is wrong. And she insisted on having her scans again. So this time a HD OCT was done, and again we found the contour and everything to be normal. But since the patient was symptomatic, we did an angiography. And this is the multicolor photo and the autofluorescence. You can see there's a little bit of a scar here up. And now we'll go to the FFA, which kind of, so if you just look below the scar here in this area, first this is the early frame, the mid, and the slightly later frame, you can see this tiny CNVM lighting up. And these are even the later frames, and this becomes a little fuzzy. So it's something, it's not at the center, it's a little above fixation, but she's so perceptive that this was causing her a lot of bother. This is of course the left eye with the scar. And now again we reviewed her OCTs. So the learning from this is that you always have to listen to the patient. And here you can see now this below one is the 2018, and you can see this tiny CNVM, which is seen in a different section from what the printout was given. And again, then when we went through all the scans and we actually sat on the machine and we kind of located, you can see this tiny CNVM, which is marked with this red arrow, and it's just below the scar here. and there's no other way it could have been seen otherwise. We gave her 2 anti-VEGF injections. She felt much better. We repeated the imaging, and you can see this is prior to anti-VEGF, this tiny CNVM, and post anti-VEGF, it's gone down. Here you can see nicely on the reverse grayscale, which also shows up these images beautifully, you know, with the reverse, and you can see how the CNVM has gone down. And we repeated an FFA. FFA also shows, and in fact, I just put the 2 pre and post together so that you get an idea. This tiny dot here, and it's gone. So don't dismiss, don't make a mistake. You have to take the patient really seriously, see all the sections yourself, and especially myopia, where the CNVM is very small, the exudation is minimal, you may not have much SRF. I think this can really save you. Thank you.
Thank you very much. I think the learning point again is the symptoms of the patient. So if your patient is symptomatic, whether the patient is choroiditis or myopic, but if the patient complains of recent onset metamorphopsia or diminution of vision, I think that's very important, and you need to really image the macula very carefully to look at the CNVs. I think to end the IC, I'd just like to call Dr. Atul Kumar sir for his talk on myopic tractional maculopathy. He's an expert on that, so he'll give us certain tips on how to manage these patients.
One more very important point about that case is always go through all the sections in such patients. Many of the times the technicians say just upload the foveal section when the patient comes with metamorphopsia kind of feature. So going through all the sections, looking for any kind of subtle RPE abnormalities or a small PD or anything is very important in all these cases. Yes.
Thank you once again, Aniruddha and Jay. So surgical pearls in treating myopic. So you got to understand that not only can you get myopia is a problem in basically because you can get myopic CNVMs, you can get myopic macular holes, you can get this kind of a picture where you have a schisis in the inner layers of the retina and the outer layers of the retina in myopes, in high myopes or pathological myopes. So once you have these inner and outer retinal layers schisis, the retina kind of starts getting rigid, the ILM gets rigid, and what you have is a staphyloma, taut hyaloid. There's a vitreous which is split, there's a retina which is split, the hyaloid is taut, the ILM is very rigid, abnormally rigid in these pathological myopes, and the staphyloma which is working in the opposite direction to cause this stretching and subsequent schisis in the multiple layers, which we call as compound myopic macular schisis. This has been a condition which is now seen quite often along with other complications of myopia like myopic CN, which Darius just showed. So this is one of the patients which showed up to us, and there was diminution of vision, and so we saw this. Swepser's OCT is important to get the imaging to pick up what exactly is there, and we found there was a schisis, but there was a macular hole. If you don't treat these patients, this macular hole is finally into a RD. Otherwise, there was a central RD and a macular hole also. You can see the degree of staphyloma formation was extreme. The eye was reaching about 30 millimeter axial length. These kind of patients, the left eye, because it had a detachment also, you have to take them very carefully. We have to peel off the hyaloid, and you can either do it with the help of using some triamcinolone powder, and you can do the IOCT with it, and you can also use the finesse loop to get this, vitreous schisis, split schisis, which is still attached. The outer part of it, you can peel it off. And once you've done that, you can put some brilliant blue G dye and put some perfluorocarbon liquid, because this is a very thin retina, so you need to really stabilize this retina. Some dye of the brilliant blue G is gone underneath, so the advantage of the IOCT device at this time for these myopic maculopathy cases is that it can tell you that the flap is actually over the hole. Because there is no contrast, the hole is often not so well seen under the perfluorocarbon liquid. So you can just get these flaps, blue stained flaps, which are very thin, and the retina is extremely atrophic and thin, so you got to be very careful you don't pinch the retina. And once you get the flap on the hole, the IOCT will tell you that it's actually covering the hole, and you can take out the carbon liquid and exchange with air and subsequently with gas. I usually put gas because in staphylomatous eyes it's better to put gas. This was a pre-operative picture of that patient, and this is a post-operative picture. In fact, this lady also suffered trauma because of her poor vision, because of an inherent myopia, but still she didn't detach. But these patients are, you know, you have to operate if the schisis starts progressing. Now, actually, it is the main thing is when you don't have these holes in the macular holes, you have a myopic traction maculopathy, it is said and it is widely believed that what you have is a very thin retina in the center. Its schisis is on each side, there is a central detachment, but there is no hole. The retina is extremely thin, it will develop a macular hole. So in case if you don't have the hole, then please do not peel towards the center. You actually do a center sparing or a fovea sparing ILM peeling. Because this fovea is so thin, and at the minute you do the ILM peeling, you most probably will end up with a postoperative macular hole. So Shimada from the University of Tokyo has done the pioneering work on this, the fovea sparing ILM peeling for MTM eyes or myopic traction maculopathy eyes. So what I do is I peel the ILM and leave the central ILM in the center, because once you relieve the traction from all around, then there's nothing to worry, the retina does settle back. You can see the retina is kind of relaxing and there is no hole formation. We got ILM on it. So this is the end of surgery. Thank you so much.
Thank you, sir. Thank you for the wonderful videos. And I think with this shortage of time, we'd like to end the session. Thank you all the co-instructors and the audience for a very interactive session. Thank you very much.